G'day, welcome back to the BroomeDocs podcast, and it's another episode of the First 10 and EM Journal Club with Justin. G'day, mate, how are you?
Things are good over here. We finally hit summer and then instantly became way too hot to go outside. So that's classic Canadian weather. You just complain about it no matter what season it is. How are things back in Broome?
It's beautiful in Broome at the moment. Actually, it's absolutely perfect. I don't think we saw a cloud, but I did see a cloud, and I don't know if you saw. I sent you my sunset picture from this evening. It was pretty cool. Those aren't actually clouds. The Aboriginal people like to do backburning at this time of year, so they go out into
Okay.
they go out into the country and burn all the dead wood essentially, and so it just makes these huge, beautiful sunsets because there's all the smoke up in the atmosphere. So yeah, absolutely spectacular.
Very cool. Yeah, I was going to say, if you ever complain about the weather to me, the podcast I think ends at that point. I've been to Western Australia; it's great at all times. I don't care what you're dealing with. I guess maybe the monsoon where you are, and you can't get to work because you need a little canoe or something like that. That's the one time you're allowed to complain.
It's all right. You can fight the crocodiles away with the oars. It's fine. Can't complain.
Yeah.
All right. So this is another month. We've come back close to our last episode, and this will be released in June for those of you who are keeping track. And we've managed to narrow it down to 7 papers this month. So what do you reckon, Justin? Can we crack the 1 hour mark? Can we get under that magic 60-minute threshold?
Yeah, I don't think that we've ever chatted for less than an hour. We can try, but I don't know. I'm feeling particularly verbose this morning, so we'll see how much rambling on I do about any of these papers.
I do listen to quite a few podcasts where people sort of have podcast length anxiety, and you listen to Weingart, he's always like trying to get it in under the magic 15, 20 minutes or whatever. I don't suffer with that affliction whatsoever. I'm just happy to chat, so it's all good.
Yeah, unless we were paying by the minute. I don't know. We just put it. Maybe that's why Weingart has more people who listen to him than us. I'm not entirely sure.
It,
But we'll see.
it could be that he's much smarter and more brilliant than both of us put together. So there you go.
I'm not willing to say that out loud and permanently on the record, but I think he knows.
Cool. Actually, I just recorded an episode with Scott last week, so I'll be heading over to MCRIT, I don't know, some point in the next 6 months. I'm sure he's got a backlog, so cool.
Indeed. Great.
All right, well, let's jump in. First paper. I'll do the intro. This is a very excellent paper, and I'm sure we'll create a few ripples in the toxicological world. So the paper is entitled The Effects of Non-Invasive Airway Management on Comatose Patients with Acute Poisoning, a randomized clinical trial. The lead author is Freund, and it was in JAMA 2023, so just around Christmas time. And this is an interesting paper. I think the title is actually a little bit misleading because when I hear someone say non-invasive airway management, I'm thinking they're slapping a mask on and putting the blower up their nose, which is not exactly what they did. So this is essentially a trial of whether we should jump in and intubate people who have come in with the magical GCS 8 equals intubate if they're intoxicated versus watch and wait and see what happens. So Justin, do you want to run us through what they actually did in this paper?
Yeah, this is the one paper that I may rant for way too long. This paper is so bizarre to me. There's so many very strange decisions in this paper. So when it initially was published, I threw it straight in the garbage and didn't bother talking about it. I figured everybody would do the same, but then everybody on social media and FOMED started talking about it as if this was a good paper. So it sort of got bumped back up, and then I was forced to read it for Journal Club anyway. So it gets onto our specific Journal Club. Essentially, it's an unblinded multi-center trial from France. It's 20 emergency departments. A little more than half of them include pre-hospital in the European style with emergency physicians in the field. So it's essentially still emergency department. For some reason, there's one ICU thrown in there. I don't know why you would run a trial that's an emergency trial with just one ICU. Either ICU should be important and there should be multiple, or there probably shouldn't be included, but that's there.
I think that was because some of their patients go directly from the paramedic team in the field directly to the ICU and bypass. So maybe that's why. Yeah.
Maybe it was a funny little lonely ICU, but all good. Basically, they took adult patients who were suspected to have acute poisoning with a few exclusions and randomized them to either standard care, which in this case, the decision to intubate was left to the discretion of the treating physician, but in general, they were pretty heavy-handed with intubating here, to the intervention, which was withholding intubation unless some specific emergency intubation criteria were met. And we can talk a little bit about those. The exclusions were mostly standard, although some of them didn't make a ton of sense to me. And one of the biggest problems is if the patient, quote, had an immediate need for intubation, which in one of these trials of intubation, sort of defeats the purpose. If you're excluding everybody who you think needs intubation and then asking, does intubation matter? That's sort of undermines your trial a little bit. But their definition of need for intubation immediately was a little bit sketchy to me. They include things like shock, and in general, intubation doesn't solve shock, but also just their definition of respiratory distress. And actually, didn't make it into my notes, but essentially was based on hypoxia, not responding to nasal prongs. But in toxicology, if a patient is hypoxic, it's almost never lung disease hypoxia. It's almost always airway, which you could say is an intubation, but essentially all of those airway issues for me respond with a nasal airway and a little bit of a jaw thrust or sitting the patient up. And they don't make no mention in this paper of just basic airway maneuvers, which in my mind is almost all these patients need. So even the inclusion exclusion criteria for this paper are a little bit funny to me. And I realize I'm already talking for 10 minutes and we haven't even said what the primary outcome is. We haven't said how many papers we'll go. So the primary outcome is going to be interesting. Well, I think this is your maybe favorite part of this paper is the statistics that they went through here.
Yeah.
Because it's a composite, but they did the composite outcome different than usual in that they did it in these weird it's a hierarchical composite outcome. So they looked at death first, then they looked at ICU length of stay, then they looked at hospital length of stay. But that's a composite outcome in just over 230 patients. And lo and behold, not intubating these patients looks like it has better outcomes based on that primary outcome.
Well,
there's a bunch
maybe.
of weird things. So they're pretty heavy-handed. So in the full in the control or baseline group, about 60% of patients were intubated, as compared to in the intervention 16% were. So there was a pretty significant difference in care with intubation. But really, the only thing that changed, and this is, I have a number of issues that we're going to go through with this paper, but there was no change in death, which is the top level. So the only thing that changed was ICU length of stay. So essentially, if you back this all the way up and just think about what this trial asked, if we intubate more people, do people spend more time in the ICU? Does intubation lead to ICU care? Did you need to run a trial to ask that question? Because that is literally the only thing that this trial answers. They asked, does intubating lead to ICU care in an unblinded trial? So right off the bat, you could run this manuscript, this methods by me before you even ran the trial, and I would have told you this is stupid. Like it doesn't ask a question that needs to be answered because of course intubating leads to more ICU care. Anyway, I've been rambling on. I'll let you throw in some comments and maybe I'll say a few more things that drive me nuts about this paper.
Yeah, there's a lot to unpack in this paper, and at the very least, I guess you could say that it does give us some observational data about what happens if you just leave these people and don't intubate them, because I think a lot of that speaks to the culture of the different hospitals, because some hospitals are obviously a bit more gung-ho with their intubation, and certainly I work in two hospitals, one that has an ICU sort of 2 floors up, and if you want to intubate someone for tox, you can just do that and they go to the ICU 20 minutes later and it's all sorted. Versus my other hospital, whereas if I intubate them, I have to stay with them and it takes, $40,000 and 2,000 kilometers to get them to an ICU. So, it's good for that point of view. It sort of says it's not entirely necessary, but we sort of, to be honest, I think I've been doing this trial secretly in my own Broome ED for about 20 years now, in that we have a lot of drunk people that turn up and we know that if we intubate them, we're going to have to undergo this huge logistical challenge of getting them out of there. And so we've been doing this for years, where most of the patients in this trial were intoxicated with alcohol, some benzodiazepines and some other sort of neuroleptic agents. But pretty much it's the standard sort of ED mix that we see in Australia and probably in America as well. So I think that we've sort of all been doing this trial ourselves, but it's nice to sort of have some data. And I do quite like this hierarchical statistical methodology. Like obviously there was no mortality in either group, so it's hard to say too much about it. And I agree, ICU length of stay when the intubation is the cause of the ICU admission is a really ridiculous outcome. I think just looking at the intubation rates is good because then it sort of tells you, well, 16% of the time you're going to end up intubating people if you just sit on them, whereas if you jump on in and have an aggressive sort of departmental protocol, you're more likely, like 2/3 of the time, you might end up intubating. So that's useful statistics.
Although I guess I'll interrupt. Did any of the 16% actually need to be intubated? So this trial really doesn't look at an outcome that can tell us
Sure.
that at all. And I'll emphasize it. So 2/3 of these patients were drunk, and I think what's most surprising. So I heard Simon Carley talk about this paper. Or at least I read what he wrote about this paper, and I think in Europe they're very heavy-handed in intubating these patients, but 2/3 were drunk. Until recently, there's been some liability issues and concerns from the police, but until recently, these patients didn't even come to the hospital in Canada. Drunk patients went to the police drunk tank. They slept it off overnight. Obviously, drunk patients don't need to be intubated. Like I have never even thought about intubating a drunk patient once in my career. It didn't even cross my mind. Now,
Yeah.
like the outcome is interesting because there's always these stories. I remember there was a story where when we were in high school and everybody learned how to put their drunk friends sleeping in like safety position on their side because there was the one aspiration
Yeah.
death. And so aspiration is a real thing. And if they had told me they were going to look for aspiration pneumonia or something like, I mean, I'm worried. I leave these drunk patients and I go away and overnight and maybe somebody's going to aspirate when I'm not looking. So I'm not saying that my approach is 100% right. Maybe these patients do need a more protective airway than what we've been doing in Canada, although nobody's been intubated in decades and there's no bad outcomes that I know of. But this trial just did not look at that outcome. And as I say, the drunk patients, you're right. The observational trial wasn't even in emergency departments in most places. Like you walk through a park in Toronto, and I can tell you that these patients don't need to be intubated. Like,
Absolutely. as, as an interesting observation is that we have a lot of people that drink to the point of stupidity on the street in Broome a lot of the time, and a lot of the time they come to no attention to the hospital at all. But during the dry season, when there's a lot of tourists, we have a lot of ambulances called by well-wishing sort of people who see these people and go, "Oh, we better call the ambulance. This person's passed out drunk," and they were doing just fine on their own. But then we watch them in the ED, and it's safe, and we like to provide a safe haven for people when they're in that vulnerable state. But at the end of the day, and interesting, they vomiting was a sort of exclusion criteria. So I think you have to take that off the table if you're going to do this trial and look for aspiration, because obviously people vomit all the time when they're drunk and still protect their airways. So it's a messy design. I will say I do like this Finkelstein-Schoenfeld, which I just want to explain to the listeners because I think it's quite interesting. So essentially, what they do is there's 100 odd people in each group, and they sort of run this simulation where they match every single person in each group with a person from the other group, and then they run a comparison. So it's kind of like reinventing what would happen if two patients turned up at the same time to your ED, and one you did the aggressive management, and one you just left and didn't intubate. And so you end up with 12,000 something pairs of patients to compare when you run it through the simulation. So it's and then there's a hierarchical outcome, and you either have a win, i.e., this group won because they didn't get intubated and they did fine, or this group died so they didn't do well. And there's a hierarchy that you go through the sieve as you go through the different outcome points, which may or may not be the correct ones, as we've just said. But it's a great way of looking at it, because it's basically what we all sort of do in our heads over our career is we go, well, last time I did this, and next time this other guy did this, so I might do something different. And you sort of remember the wins and losses in your head. So it's a way of calculating that in a sort of objective fashion, I guess.
Yeah, I thought it was really cool at first glance. The more I think about it, I think this might confuse us to some extent into making some bad conclusions. So it's a really cool way of dealing with composite outcomes, but composite outcomes are bad. So first of all, you need to make sure that all the components of the composite make sense. And this one from the beginning, the ICU like to say made zero sense. So including composite outcome points that make no sense are silly. But I think more important than that, your if you really had multiple outcomes that you thought were really important. So let's say you're doing a cardiac trial, and number one, death. We all agree that death is really important, and we're going to ignore most of those MACE outcomes. But number two, you said, look, if we can't prevent death, what I'd really like to prevent is MI. And if you said those were your two outcomes and you wanted to run it through this technique, great. That's semi-reasonable. But all you're doing is, I think, softening your stats. If you told me, look, I want to run a trial that has two primary outcomes that are hierarchical. And first, we're going to look at death. And if death is positive, we're stopped. Like, we don't need to look any further because that's the important outcome. But if death is negative, we're actually going to run it again. And we design the trial this way from the beginning. We'll look at MI second. That's great. But what you need to do is adjust your stats for making multiple comparisons. They don't do that here. So if they said, look, we're going to look at death first, and we're going to use our normal p-value of 0.05, and we're going to look at ICU length of stay second, and we're going to use a p-value of 0.0005 because that's how you, like, whatever the actual stats work out to be. That'd be fine, but then you don't need to use this method. You just need to say we're using ranked. I still think a composite outcome is a bad idea, and I think having ranked outcomes and explicitly saying here are the outcomes, secondary outcomes that are most important, and looking at them one at a time rather than what we usually do is here's a bunch of secondary outcomes, and we're just going to like measure everything. That pre-registering secondary outcomes that you think are the second and third and fourth most important makes sense, but you got to adjust the stats for making multiple comparisons, and they don't do that here. So if lots of people adjusted to this technique, I worry that you would start getting positive outcomes that are much softer than what you're used to, and not recognizing actually secondary outcomes, if you know what I'm saying.
Yeah. So what you're saying is if you're going to have multiple secondaries or composite outcomes, you need to have a higher burden of proof as you go down that list of different problems. So let me ask you, Justin, if you've got one of those classic stroke trials or resus trials where it's like death and then neurologically intact survival, which order would you put them in terms of your hierarchy? Would it go neurologically intact survival and then death? Or I don't know, like it has to be death first, doesn't it? I don't know.
No, I don't think so. I think you rank them by what you really think is most important, and I think that shouldn't be us most of the time. The one thing I loved most about that Paramedic 2 trial all the years back is before they ran the trial, they asked the local population what's most important, and they all said, "Yeah, my brain is more important than just being alive or dead." And all of our patients know that. That's why we have DNR orders when bad outcomes are there. So yeah, I think you got to choose the outcome that actually is important. Now it is a little bit funny to work backwards and to say death might be a secondary outcome, but I think we all know that that's the case. There are fates worse than death.
Cool. All right. We should move along then we'll agree that you probably should not intubate French people. Is that what we're going to say?
Yeah, I mean, the sad thing about this trial is, and apparently a lot of people around the world need this lesson, and so this type of research maybe is really important. That they got the right answer that we shouldn't be intubating just based on a GCS cutoff. We shouldn't just be intubating all the tox patients, but this trial doesn't actually say that at all. So if you want to be truly scientific, this trial says absolutely nothing of value, but it's still got the right answer. So that's sort of frustrating.
But if you just read the headlines, whatever you do, don't just put a BiPAP mask on all of your drug patients. That won't help. Because that's when I first saw the title, I thought that just sounds crazy, but it's got nothing to do with BiPAP masks whatsoever. So read beyond the fine print. Cool. All right, we'll move on to. I guess it's dermatology time, sort of. Are we doing dermatology this month?
We're trying to transition. I heard dermatologists make a lot more money than emergency doctors, so I'm slowly trying to transition our podcast into dermatology and see if that helps.
All right, you do the intro.
Yeah, I heard this one a lot around social media, which is why I went and grabbed the paper. It's the syringe hickey, and the title of the paper is "The Syringe Hickey: An Alternative Skin Marking Method for Lumbar Puncture" in the Journal of Emergency Medicine 2023. So I don't know, Casey, do you have a problem with marking the skin for your procedures? They specifically were looking at lumbar, or talking about lumbar puncture here.
I do. I hate it. I completely think it's the wrong thing to do. This is a technique which I think just needs to go the way of the dinosaurs. So when I was a young anaesthetic registrar and I was learning how to do cesareans and spinal anaesthetics, I had this very ancient old anaesthetist that used to walk up, get the woman in the position to sit on the edge of the bed, and we're going to do the epidural or the spinal. And he would walk up and he wouldn't say anything. He'd just take his ballpoint pen out and just draw a single dot on the woman's back, without even palpating her back a lot of the time, just sort of like going, like using the force to sort of sense this is the spot and like draw the spot. And then And I found that incredibly distracting. And the other thing I find really distracting when I'm doing like particularly lumbar punctures or epidurals is a lot of women have that lower back tattoo nowadays, and often it's like just like half a centimeter off the midline, and it's like your eye just wants to go in that line of the tattoo, but it's often not the right line, and so it's all about the feel, and it's not about the actual mark. And I think I use my index finger, and especially when you've got a moving target, like doing it in the ED where you've got a lumbar puncture in someone who's either sedated or compliant with your instructions. But when you've got a woman in labor who's thrashing around and trying to sit still during contractions, it's all about having your finger on the right spot and essentially using your local anesthetic needle as a marker needle, as a guide. Because once you've got that needle in the right spot, the rest of the procedure is pretty easy, pretty much. So I think I just use my finger. I put it on a spinal process, make sure I've got it on there, and then I use that to guide my needle in. And I find the use of marks on the skin, one, they can be just offline, which can really throw your eye out and make you deliberately go off course. And two, um, the skin moves. So particularly in people who are a bit bigger. So if you have a larger person, you're trying to do a lumbar puncture and you put a mark on and then they arch their back a little bit or flex as you get them into a better position, that can move a centimeter and that can really throw off your target. So I just think you've got to use the force of the index finger to find your spot. That rant
Yeah,
over.
yeah, I tend to mostly agree. So I don't, for lumbar puncture in particular, I don't mark the spot where I'm going to stick my needle. I do mark routinely, but I mark 3 spinous processes in a row right on the bone,
Right.
just so I know what straight up and down is. Because very frequently you get everything set up and they've just twisted a little bit, or they're a little bit offline, leaning left or right, or especially if you're doing it lying down. So I like to have a visualization of what straight up and down the spine is for midline. I mean, if you're doing spinal anesthetics, you're doing this a lot more than the occasional lumbar puncture in the emerge. So you probably don't need that as much as I do. But I like a mark of the midline. But it's, for me, I'm marking the bones, not that single mark of I'm going to go here. Yeah, the patient moves around enough that fails all the time for me. But a couple marks of here's where I think the spinous processes are. Even if you move around a little bit, it gives you a good sense of a straight line up and down the spine. I find we haven't even talked about what the paper is. Essentially,
Sure.
the syringe hickey technique. I think most of us, there's a lot of different ways. Their argument is, if you use the markers that come in these techniques, and then you use some chlorhexidine, it's just going to wipe off, and that's true. I think Scott Weingart taught me if you just buy an industrial Sharpie a long time ago, it doesn't wipe off and is alcohol based, so it actually sterilizes. Like it's perfectly fine to use. But
Yep.
I think what most of us use is you just use the back of a syringe or back of a needle or whatever, and you just push for 5 seconds and you leave a little indent in the skin or something like that. That's fine. They're worried about that, and so what they describe is taking a 10 mil syringe, pushing it relatively firmly into the skin based on this, and then withdrawing it back to 5 mils. Sort of the idea of leaving a hickey on the skin. I don't actually think that they're leaving a hickey at all. If you look at these pictures, there's no
Yeah.
burst blood vessels at all. There's no like actual hickey. They're just making a deeper indentation by providing a little bit of a vacuum. So I'm not sure that it did anything. And the biggest concern to an emergency doctor is the technique takes a full minute. Who the hell's
Wow.
spending a minute marking the skin when both of us don't even think marking the skin is all that valuable? I spend 5 seconds and I get the exact same mark by just pushing into their back in 5 seconds that they seem to get in a minute. Now, they brag that their mark lasts for 30 minutes. Man, if you're still trying a lumbar puncture at the exact same spot 30 minutes later, oh my, like, you will have so many more problems than just marking the skin. So yeah, if you ever hear somebody refer to this syringe hickey technique, it is this sucking back on the syringe to apparently make a little hickey on the skin. There'll be pictures in the show notes of what they did, but I think this is silly personally. I tried it a few times because originally I was excited maybe it would hurt less, maybe it feels different for the patient. It doesn't. You still have to push into their skin. This to me is useless. I throw it out.
Yep. Absolutely. Happy to throw it into the garbage bin. It's a waste of syringes, you could argue, if they're into plastics recycling. So, cool. Yeah, I don't think we need to say too much more about that. By all means, if you're really struggling, though, my only other tip, if anyone out there is learning and they've had a struggle recently, if you've had a pass or two and you just keep hitting bone, the best thing to do is just put down all the tools and just repalpate the spine and make sure you've got the midline, because like 95% of the time is because you're not on the midline. So that's all you got to do is find that midline and just take a little deep breath, put the sharp things down, and just feel that back really carefully, or get the ultrasound out if you're adept at doing that.
Yeah, this is not a paper about lumbar puncture, but the other thing that I still find a lot of people haven't heard, I think we talked about it on the paper before, is that the whole stylet in the lumbar puncture needle is for the dermal layer. It's well documented that you can take that out once you're into the subcutaneous tissues, and that makes all the difference. If you're advancing without the stylet in, as soon as you're in the space. If you advance the entire way and then like try to pull the stupid thing out every few seconds, it's so much harder to find that space. So you need it in so you don't get a dermal plug. But once you're through the skin, you can advance with the stupid thing out, and like all of a sudden, this lumbar puncture became so much easier. But that still requires you to know the anatomy, and just spending. So I think the big problem when you're training is you seem like you're telling the patient you don't know what's going on if you spend an extra 3 minutes palpating. But if you do this for a while, experts take the time to feel the anatomy. And I think learners are nervous that if they spend a bunch of time, the patient's going to get ramped up and anxious. And I think you can just talk your patient through that. Tell them it's really important that I feel where all your bones are. I'm just going to take a good feel around. I'm going to take my time. I will tell you before I do anything painful. And I feel actually the patients start relaxing and take a few deep breaths. So just take your time. That's the key to a good procedure.
I will second one thing that you said there is talking to the patient, because a lot of the procedures that we do in medicine, like putting drips in or whatever, like the patient can look down and see what you're doing, but there's nothing more anxiety provoking than someone standing behind you where you can't see what's happening and they're quiet and you can just feel them poking on your skin. So keep talking the whole time and reassure them that you're going to tell them everything before it happens, so they don't get
everything.
any
Like even
surprises.
just opening the container, like people start freaking out because like you're making noises behind them. So I tell them, like, I'm just opening things up. I'm just gonna get some cleaning stuff ready. I'm just gonna get the like just literally walking through it. I has been a game changer for me. Just like it's maybe embarrassing, although like, you know me, I can just talk and talk and talk and talk. But just like visual, like what I'm trying to say, just verbally saying exactly what you're doing, I think helps patients a lot. There are some that don't like the medical terms as much, and you got to feel your patients out a little bit, but letting them know that before anything touches their skin, here comes the alcohol, I'm just putting a drape on your back. Oh man, it makes such a difference.
Yeah, absolutely. Cool. All right, we'll move on to the next paper. I can't think of a good segue, so we'll just jump right in there. This paper is entitled "The Invisible Gorilla Strikes Again: Sustained Inattentional Blindness in Expert Observers." It's in Psychological Science from 2013, so this is more than a decade old. We're going back to the old days. And it's not that far ago. It's about when we started chatting. So that's probably
it's hard to make fun of radiologists, so I have to dig pretty deep to find a paper that says anything bad about our wonderful radiology colleagues.
So the lead author is Drew, and this, for those of you who aren't aware of this concept, just go onto YouTube and Google the Shabry and Simons trial, which was, I don't know, it's done in the 80s or 90s, I think, from memory. And you can watch the YouTube video and just watch it. Don't read it first. Just watch it from start to scratch and have a look at it. So essentially, it's a test of inattentional blindness, and it's a famous video in which people miss a gorilla in a scene. So that's all you need to know. So go and watch that first, and come back and listen to this because it'll make a lot more sense. So Justin, tell me, what did they do to these poor radiologists to make them look stupid?
Yeah. So it was like they obviously didn't tell them the purpose of the trial. They got 24 radiologists together, and they had a couple minutes to review 5 different CT scans. And they were told their task specifically. They were told they were trying to identify lung nodules. So they had something that their brain was specifically looking for, and then built into one of the CT scans was a very obvious, ridiculous cartoon gorilla, and the radiologists honestly were pretty good. It was a challenging task. They only found about 55% of the nodules, but it was specifically challenging. But of the 24 radiologists, 20 of them didn't see the gorilla. In an audio podcast, that might be a little bit hard to understand, but you should go and look at the pictures from this paper. We'll get one up.
It was a big gorilla.
It's a big freaking gorilla. It's just sitting there. Now they compared, like they made some interesting comparisons. If you really want to get into the psychology, they had non-radiologists just look at these. and they were worse than the radiologists. They only found 12% of the nodules, and none of them spotted the gorilla. So at least the radiologists, a few of them saw the gorilla, and they found the nodules a little bit more often. Like this paper is mostly for fun, but I think it's worth taking a larger step back and thinking about what attentional blindness really means for us in the emergency department. What this paper tells you, look, if you just if you just had the radiologists like skim through these papers without telling them focus on the nodules, they're going to see a gorilla. It's a big, giant gorilla in the paper. Their
Maybe.
eyes even look at it when they do some eyes tracking. They're mostly going to see it, or at a higher rate than the 20 to 24, although that's not here. But there are a lot of times in medicine where you have one task and one task only on your mind, and it leads you to miss other things. The classic one for us would be intubating. You get so focused on the cords, you no longer hear that sat that's now down at 70%, or you pay no attention to the blood pressure. And I think we do it a lot in radiology as well, because we know, hey, this patient has a bent forearm at 90 degrees, and you go and look exactly there in the paper, but you tend not to look at the wrist, and you'll miss that carpal bone that's out, or something else like that. So we know that the first or the second injury on the x-ray is the one that we always miss. So I thought it was just an interesting paper. I mean, it's hard to resist a paper that has a gorilla in it, but it doesn't have an immediate direct clinical implication for us, I don't think.
Well, yeah, it's interesting. I've been a little bit obsessed lately with neuroscience and particularly looking at a lot of stuff around perception. And I think what they've actually done, if you read the deep neuroscience behind the modern ideas about why this happens in our brains, is this concept of top down versus bottom up perception. And so I don't know if you've heard of this concept, but essentially the idea from modern neuroscience is that basically all of our perception of everything, but if you just think about visual perception, is that our brain basically is constantly forming a best guess. It's like a controlled hallucination as to what's actually out there in the world. And a lot of the picture that's built up is just built up from our brain's internal memories and previous experience of what might be happening out there in the real world. And then it uses those visual sort of stimuli coming in to sort of update that model constantly. And so if you think about it, if you're an expert radiologist and you've been asked to look for nodules and you're not used to seeing gorillas in CT scans because gorillas don't belong in CT scans, your brain's not going to generate that hypothesis. So even if the photons bounced off that gorilla and went into your eyeball, your brain's not going to perceive that as something because it doesn't match the model that it already has. So it's sort of like a Bayesian thing. Like your brain's going, there's a 0.001 chance there's a gorilla in this scene. And if it sees a gorilla, it might bump it up a little bit, but it doesn't cross that threshold of I've seen a gorilla. So I think that's what's going on here. So I think they've just demonstrated this principle beautifully, that our brains are actually doing top-down visual processing, not bottom-up, because that's what we sort of get taught in medical school, that photons come into your retina, you perceive an image, it goes into your occipital cortex, but that's not actually true. And as you said, just in like that cognitive forcing strategy, what you're really doing by sort of, I was putting in a central line this morning, and I knew that I was going to have that focus where I was going to be doing that. So I just offloaded that and said to the other people in the room, I'm not going to hear things. I'm not going to smell anything. I'm not going to be aware of what else is going on. So you need to do that for me. But you just have to be aware that that's how your brain works. So it's absolutely true. It's fascinating stuff. If anyone's interested, I'll chuck a link in the podcast and in the show notes for this episode to a couple of really cool YouTube videos that describe this.
Yeah, it's probably the basis for a lot of the stuff that sounds like really, pop psychology or self-helpy. But, if you come into work expecting the emergency department to be incredibly busy and stressful, you have that overlay over it. And so that's what you see. Whereas if you come in expecting to have a fun challenge of a shift, that's what you see. Like we do filter knowledge based on our expectations very, very strongly. And so that it is probably a real way that you can hack your life, that it explains a lot. I mean, this is sort of the basics for all cognitive behavioral therapy, in that, your thoughts aren't reality. Your thoughts are just thoughts, and you have to judge them based on that. Anyway, that's a quite a big tangent, but I think there's a lot to. I've been debating for a long time, including once every month a classic cognitive psychology paper just because they're so interesting. And I think they have wide-ranging implications for us, but also I think there may be a little bit too loosey-goosey. So I haven't committed as of yet, but we might get a few more of these kind of papers in the future.
Yeah. I was talking about this concept with one of my colleagues who's a psychiatrist, and he said, "That's really interesting. What does it do for me?" And, like, I still have to treat humans, right? So yeah, that doesn't actually help you if you are a human or if you treat humans. It's of no benefit whatsoever. So you can't hack your own hallucination, as it turns out.
Nobody's ever said that our podcast helps humans. That's not a thing. So it's okay. All right.
Cool. All right. We'll move on to the next trial, which is a trial about trials which are about smaller trials. So this is like a whole Russian doll nesting situation going on here for EBM. So I'll do the intro. This is entitled Positive Single Center Randomized Trials and Subsequent Multi-Center Randomized Trials in Critically Ill Patients, a Systematic Review. This was in Critical Care 2023 November, and it's got a whole heap of authors, but it's got lots of people like Ronaldo Bellomo and from all around the world working on this. And essentially, what they've done here is they went back through like the big three journals, I guess you'd say, which is New England Journal, JAMA, Lancet, and they have gone back from their inception, which is, I don't know, what's 1860 something that they're in, and they've looked at single center randomized controlled trials which were done in critically ill patients. They had to be like ED ICU sort of type patients, and then they've looked at the ones that have actually shown a proper mortality benefit statistically, and they come up with a grand total of 16, which seems underwhelming in the whatever 100 years of publications that they've looked through. They've looked at, and of those 16, they only included ones that subsequently then had a multi-center RCT. So it was a trial that was done in a single center, seemed to be positive, seemed to show some sort of death of benefit to the patients in critical care. And then they looked what happened when they were subsequently done in multi-centers. And I think listeners to this podcast and fans of Justin will not be surprised to hear that most of them didn't actually show a benefit. They were neutral. So 14 of them showed no difference between mortality when studied on a broader scale. One was positive, and one actually showed that it was more harmful once the patients were put through a more rigorous statistical technique. So very interesting, mate. I'll let you rant for a bit now, and if we'll come back to me in a bit.
Yeah, I mean, it's I'm obviously a little bit nerdy, and I generally don't include these papers. I have a ongoing project where I am trying to collect as many of these papers that are sort of meta, understanding evidence-based medicine, or the science of evidence-based medicine, not of clinical care. And for the most part, I have not included these here, but I do worry that people who are not spending a lot of time in evidence-based medicine hear a lot of the comments that we make as people who read a bunch of papers and think that we sound cynical. And I think it's really important to understand that the skepticism or the negativity that sometimes comes through really is science-based, and it's partially experienced because you see it all the time. These papers where you're like, well, that's a pretty crap paper, and then a decade later, it is proven to be crap. Whether it's like therapeutic hypothermia or whatever, with big trials that end up being negative, or just trials like this that tell us that in medicine we have a false positive problem, and that should be very obvious. So in physics, you use something called 6 sigma, or your p-value has to have 7 zeros before it becomes significant, whereas we use 0.05, so 1 0. So like, it's not just one order of magnitude. We're using science that is 7 orders of magnitude less certain than they use in physics. And that always struck me as funny. Like, I understand we have to do something at some point in medicine. People's lives are on the line, but which is more important, knowing for sure that the existence of the Higgs boson, or giving people chemicals that could influence whether they live or die? It seems like we need more certainty in science, or in medicine, but we do it the other way around. So I think it's really, really important to know that when you hear a small single center trial is positive, or just any trial is positive, it is very likely in medicine that a subsequent trial will prove it wrong. That's before you even get into bias and everything else. Just by the stats that we use, false positives are hugely problematic. And I think that is so important because this is looking at, as you said, there's in the history of the three biggest journals here, there's only 19 positive single center RCTs that actually showed a mortality benefit in critical care topics. Think about the number of other things where we've tried to, or people have suggested changing practice without even showing a mortality benefit. The example I use in this write-up is PPIs and GI bleeds again. There's been never a positive trial. There's been a couple secondary outcomes in various trials, and yet people have based their practice on that. Even if there was a single center trial with a mortality benefit, it probably would be negative. It is 100% negative when you have just trials that show secondary outcomes that are negative. So again, I think we sometimes sound very, very negative, and I think people need to know there is a strong reason for that, and it's just the whole basis of medical science is incredibly lax in terms of the results that we do, and so that's why I threw this paper in there.
Cool. Yeah. I'll just for a bit of interest for the audience, have a pause, listeners, and have a moment to think which single center trial that had a mortality benefit went on to be proven in a multi-center out of all the 19 trials that have been published in those big three journals. And it was, drum roll, it was the paramedic 3 trial. So we've already mentioned that earlier on. So adrenaline for out of hospital cardiac arrest. And interesting that we've already mentioned that, because I think from memory we quite liked that trial because it was looking at neurologically intact survival, and it was a really well done trial, and maybe didn't line up completely with what we thought in the past. So interesting.
It's especially interesting because if that is the only positive trial, I didn't know that. Good kudos on digging deep, but I actually still think that was mostly a negative trial. It is true that there was a mortality benefit, but there wasn't a good neurologically intact benefit. So if that is the only positive trial, that is really, really concerning.
That was the only one. The one that was went in the negative direction was intensive glucose management in the intensive care unit. So high, really tight glycemic control. So yeah, we don't do that anymore, thank God. So it looks like it's gotten out of the literature. So awesome. Let's move on to something smaller and pediatric, should we?
Let's do it. This is a friend of the in the full med verse reason we picked this one up.
Yeah. This is a trial that was published by a whole group of people, but we had to do a shout out to Ben Lawton, who's one of the original Don't Forget the Bubbles team over there in Queensland in Australia. And this trial's entitled Novel Peripheral IV Catheter Securement for Children and Catheter Failure Reduction, a randomized clinical trial. So this is this. I do like this because it's looking at one of those things that we do all the time, and it's just looking at a different way of doing something that we've done the same way for many years, or at least I have anyway, and asking, is there a better way to do it? Is there some way that we can actually make this child's lot better in their stay during the hospital? Because IVs in kids are a very big sticking point when it comes to their journey through their healthcare. And if you only have to have it done once, that's obviously better than having to have it done 2 or 3 times. You would think that would show this.
Great pun. I'm not sure. A sticking point for IVs was just brilliant. Anyway,
they're coming in voluntarily now, Justin. I don't know if that's a good thing.
Your dad brain is just burnt in there.
It's on overdrive. So essentially, this is an RCT which involves basically taking kids that need to have a drip put in, and there were about 380 odd kids who are being admitted through the ED, and they thought that they're going to need to have a drip in for at least a day, and they compared a couple of different techniques, and basically there was the standard sort of Tegaderm dressing, which we're all sort of familiar with, and there was this new brand name. Integrated securement dressing ISD, which was called a Sorba View, if you're following and want to buy this. And then they put some tissue adhesive, so some Dermabond or skin glue, underneath the drip dressing as well to make it stick down. So that was quite interesting because it's not something that many of us would do, and but certainly something we have access to in our emergency departments. So it wouldn't require a lot of capital outlay to start doing this. And bottom line is that there was a pretty big improvement between the groups. So comparing the new device with the tissue adhesive, only had about 12% failure rate, while the standard care group was about a third of them failed. So that's if you're following along, that's about a number needed to treat of about 5, I think, is it from memory, something like that. And they looked at a heap of secondary outcomes as well. Interestingly enough, though, the satisfaction ratings were the same, no matter how many drips you got. So that's a fascinating point, because I would have thought that would be probably the most patient-orientated outcome. And there's not whether or not your drip fell out, but did you enjoy your hospital experience as a result of that? So interesting. Any
Yeah, it makes
points?
me wonder whether the dressing is really uncomfortable, because, like, it's weird if your kid got poked multiple times, you think you'd have to be less satisfied, but maybe there's just an overlay of, if my kid's healthy at the end of the day, I'm satisfied. It's a little bit hard to say.
Yeah, yeah.
I
I
mean,
guess that is true, because I know a lot of PEDS trials I've looked at in the past. Like the satisfaction rates are like 99% in both groups, no matter what we
yeah,
do. So it may be hard to show a difference. Yeah.
pediatricians are just really nice. They always take a chair and sit at the bedside. All those other things that we say matter.
Yeah.
I love this trial. I like a practical to actually do an RCT of a simple practical thing that can be game changing is fantastic. I think it might be game changing. I do think that from a science standpoint, you have to take a step back and be slightly concerned. It would have been hard to blind this trial for sure, but an unblinded trial is always a little bit problematic. Look, a dislodgement is a pretty objective outcome, but I've watched nurses work a long time, and sometimes you give up on the IV right away, and sometimes you spend 10 minutes sort of adjusting it and fiddling around with it and going like there. So there is some subjectivity, and you might spend more time if the IV was glued to the skin and it was going to be hard to take out, trying to make it work again. So I think you have to be a little bit concerned about bias there. And I wonder, I've been debating back and forth how much I think this is a real thing, but look, I would expect the glue to impact whether these were dislodged. That makes sense to me. It doesn't make a lot of sense to me that it would affect the rate of occlusion necessarily.
Yeah. Yeah.
And there was just as big a difference in occlusion of the IVs between the groups as there was in dislodgement, essentially. So that's a little bit funny to me, and maybe hints that there may be some bias overlying this data, because just pathophysiologically, I can't see why. I mean, I guess it depends on the joint, and a kink will be an occlusion. So there is some reason. And that's why I go back and forth a little bit. But I do worry that there's going to be some overlay in bias. The flip side of that is I'm not really sure what the harm is, and I love poking kids less as much as humanly possible. And these IVs can be hard to get, and if I'm going to put an IV in, it's very rare that I'm going to take it out anytime soon. So putting a little tissue adhesive on there and a good dressing rather than just a tegaderm, that it makes perfect sense. So my threshold for practice change is a lot lower than it is in other situations, I think. And so this trial probably is good enough, even if it's not perfect, I think.
Yeah, I think for my practice, like generally, if I'm getting called to put a kid's strip in, it's because someone else has already had a go at it. And so I'm not a very proud man, Justin. I just rock up with my ultrasound at that point, because I just find it makes everything easier. I put a ton of local in. And if I'm going to go to all that trouble to put a good long catheter in, and I usually try and put it in a non-joint part of the body, so sort of forearm or upper arm, so that they're not bending it. I think it's worthwhile to chuck some dermabond on there and hold it in place, because it just makes sense. And if you put it away from the joint and you're pretty happy it's unlikely to occlude, then I'm happy if I can glue it down and it'll stay there for 3 or 4 days or whatever need be. So that seems like a good option. Or you could just give them oral antibiotics. We've covered that before on this podcast as well. But not always the solution.
I can't remember the last time I did an IV in kids. So for the most part, this is sort of a non-issue to me. Like for inpatient practice, I assume that they're using it a little bit more, but even then it's pretty rare. There are a few vomiting kids, but most kids still, even when I'm admitting them, are drinking. And in the critically ill ones, they're not really moving around all that much. So the tegaderm may be all that, may be good enough. As soon as they're moving enough that they can yank an IV out, they're probably okay without the IV, but that's a completely different question. That's a trial I actually think I sort of want to run. The ability to yank out an IV and the need for an IV, how well correlated are they?
I've got to say, I've just worked 3 or 4 days in our high dependency unit, and there's a very close correlation between delirium and pulling out your IVs, and they definitely still need their IVs. So
yeah, I mean, adult patients are a little bit different, a little bit stronger, but
yeah. Cool. All right. We'll leave it there, and we'll move on to something that's definitely going to change everybody's practice. I think this is possibly the paper, Justin, that will change the most heads in this week's podcast.
I think so.
Can I just say, back it up here? Last podcast, buddy, we decided no more bloody Airway papers, and you've snuck this one in. Can you justify that decision?
I mean, to be fair, but I automatically included this one based on the title before even fully reading that it was a video versus direct laryngoscope. I just saw intubation in outer space, and I was like, hell yeah. So I don't like that you're giving insights into the stringency of my selection criteria, which sometimes is just hell yeah. Look at that picture of the guy intubating in outer space. Let's do it. That's what this is. Author named Thierry. Evaluation of free-floating tracheal intubation in weightlessness via ice pick position with a direct laryngoscopy and a classic approach with indirect video laryngoscopy. Actually, I guess is the name of the journal. I don't know what MPJ microgravity is, but that's our journal, 2023. Fantastic. I actually think I did a quick search and I couldn't find it, but I think we've covered intubation in outer space before. That seems like a
Pretty
topic
sure
that we might
must have.
have done. But it wasn't this paper. There's a bunch of previous papers that apparently show people in outer space are not very good at intubating. But like everybody in emergency medicine, they decided that might be just because they're trying to use direct scopes. And so video is going to be the savior. Mostly I threw this in so you can look at the picture. So if you're listening to this in audio, go check out the show notes. There's some fun pictures. They intubated facing the patient. I'm not sure why they decided to use two different intubation techniques. It sort of undermines the entire science to do face what I would have called, and it probably is very politically incorrect. I've seen this labeled as the tomahawk approach before, but the ice pick also makes sense. So you're face to face with the patient.
It's better than what I would have called it. I was going to call it the missionary style, but anyway.
Yeah, that also. And when you're floating directly above the patient, it is something. And they were I don't know who they recruited to do these intubation approaches, but the direct laryngoscopy had a success rate of 33%. And so I think you pretty quickly lose your medical license, or at least have many lawsuits pending if you are failing to intubate 70% of the time. Using a video and a little bit more classic at the head of the bed looking down the patient, they had a outstanding, statistically significant success rate of 58%. So that is better than 33%, but a good 40% of your patients are still dying. So I'm not entirely sure what this is. Fantastic.
So it's a good evidence-based medicine point there, though, Justin, that you bring up that that statistically significant difference between crap and totally crap doesn't necessarily mean it's a good idea.
Yeah, I think that's really the main, I guess, the main reason for this. I have the hypothesis. I'm not really sure. I guess if you're reading the paper, they are worried about longer trips. If you get out to Mars and somebody has a medical emergency, maybe an endotracheal tube will matter. I'm not sure that really, though. There's this bias, even in medicine, that plastic between the cords is a fundamental move. There are very few of our issues that are fully airway issues. And I think we've learned, especially in my career with the invention of non-invasive ventilation, how little that plastic in between the tubes matters in many cases. I would love to see the follow-up trial here, because basically this tells me astronauts should not be intubating unless we have emergency doctors becoming or critical care doctors becoming astronauts, which has happened, I believe. But I an LMA might be a very reasonable piece of kit in an outer space, but I would love, that's the trial I want to see. What is the effectiveness of an LMA in microgravity? Does it sit properly? Are you just getting leaks all the time? Is regurgitation more common in outer space because your stomach acid is actually just floating up towards actually, I don't even know that. This is going to be included in the next one. Is GERD more common in outer space because your all of the fluid sits at the esophageal sphincter rather than at the pylorus? That is what does digestion look like in outer space? I actually think we might do an entire outer space episode next time. We'll come back to that.
I will put that idea on the back burner, I think. Although, can you imagine working at a zero gravity intensive care unit where, like, because this isn't actually done in outer space. Obviously, this is done on one of those jets that flies up and then has like a minute or two. I think it was like 90 seconds of zero gravity time where the jet's essentially plummeting towards the Earth at the same speed, and then you've got 30 seconds. And I believe that jet's actually nicknamed the vomit comet. That's what they call it, because like half of the people that do that experience actually vomit during the zero gravity time. And so maybe that is part of their GERD. Can you imagine working in an ICU on the space station where there is zero gravity and your patients, like all their mucus secretions and everything that you would normally suction up are just floating around you in the in the ICU? Like that would be that's where you'd be using your PPEs. Like if you breathe in too deeply and you get a half chewed carrot or something, that would just be, I don't know. Yeah.
I actually think this may be the future of critical care. Think about how easy proning would be in zero gravity. Think about bed sores; they non-existent in zero gravity. Like this, it may just be that we should be sending all critically ill sick patients to outer space. I think that is the future of medicine.
Although there was a really interesting point that I think they brought up in this paper, or did I just imagine it? Where if you put the laryngoscope blade down on the patient's tongue and you get a great view of the vallecula, and then you do the lift move and you do that in zero gravity, the patient could just float off towards the ceiling, and you're left where you are because you're doing that traction, Newton's third law thing. So you would actually have to strap the patient to the bed. So it would just be like doing it not in zero gravity, essentially, because they would just float up.
Yeah, you're creating essentially artificial gravity at that point.
So it's yeah. Anyway, so yeah, if when intubating patients in space, tie them down first. Yeah, that's the yeah.
And if that one wasn't ridiculous enough, you sent me this paper, so I'll introduce it and you can tell me why this paper is so fantastic. The title of this paper is Heresy, Witchcraft, Jean Gerson, Skepticism, and the Use of Placebo Controls. And so this is a recently published January 2024 paper in, I don't know what the JR Soc Med is.
It's the Journal of the Royal Society of Medicine. That's the
yeah. All right. I love this paper. I really did. But what about it caught your eye for a podcast for our clinical emergency folks here?
Well, a couple of things, Justin, caught my eye about this. So, well, one of the things that I love about this is that since doing this podcast with you and running the BroomeDocs podcast for the last 10 years or whatever, I've sort of, I've got people that follow me and probably understand a little bit about how my brain works. And I just love the fact that people send me this sort of stuff. So this is just awesome. So if you're out there in the world and you're reading wacky literature, just go to BroomeDocs@gmail.com and send me your papers, because I just love stuff like this. But this was actually sent to me by a friend of mine, a very dear friend who is a psychiatrist. I won't mention his name because he would prefer to remain nameless. I think I called out a few people last episode, but I won't do it this time. And I thought that you needed to read this paper, Justin, because this is basically looking at the origins of the idea of the placebo in science. Well, we'll put science in inverted commas there. I just want to read the first paragraph of this paper to give you a bit of an idea as to where this is going. So in 1599, in a small town in the Loire Valley in France, a young girl became extremely behavioral with verbal outbursts and was examined by the medical commission dispatched by King Henry IV. It had been alleged that this young lady, whose name was Martha Brossier, was possessed by demons, so she'd been subjected to daily exorcisms intended to cast out the demons and restore her to health. The exorcisms were performed by priests in front of large audience so that they could see her shocking behavioral displays. So the king decided to send his medical commission to look at Martha in a private location, because they wanted to respect her privacy, obviously, where her responses to exorcisms could be closely examined without distractions. So essentially, they sent this guy, his name was Michel Marescot, who was one of the, king's top scientific men of the day. And they essentially decided that they needed to do a trial to work out if she was truly possessed by demons and needed to be exorcised, or if she was actually just a political dissident that was saying bad things about the Catholics, essentially, which was the other hypothesis, that she was just a lot of her behavior was apparently directed at the other religion that was prominent at the time, and she was causing disruption in the community. She was 16, which is, there's a lot to say about that. This is like the bad Joan of Arc, I guess you could say. She was not the good Joan of Arc. And so what they did is they basically took a heap of religious artifacts, so things like crucifixes and holy bread and holy water, an iron that was supposed to be cast from the original crucifix, and then they had essentially sham versions made, so water that wasn't consecrated and crosses that weren't actually blessed by priests and holy water and all that sort of stuff. And then the idea is they showed her the true religious artifacts. If she was possessed by demons, they would cast out the demons, whereas they showed her a dummy cross or not holy water, that she wouldn't react to it. And I just love the the fact that this went on for 40 days. It took them 40 days to do this trial, which is way more scientific rigor. Like most of the trials we do nowadays go for like 10 minutes, the intervention for the patient. We observe them for a couple of minutes, but yeah, this took 40 days apparently. And they concluded at the end of all this that the young woman was in fact not possessed by demons because nothing fixed her, and she therefore was labeled a political dissident. And I don't know what actually happened to her after that, but I imagine it wasn't good. Interesting.
Yeah, I mean, I think just being a 16-year-old female in 1600s is probably not a great place to start. But I'm not entirely sure once you have the attention of the church in this way. And this is I love the paper, as you say. I'm really glad you sent it along my way, and I think the scientific method is so good. And so interesting, and the idea of sham religious relics is really interesting. Although I think there's a problem of there's a reason people have moved away from evidence-based medicine to the terminology of science-based medicine is that something needs to be at least plausible to begin with. And I'm not criticizing 1600s had a very different worldview than you, but you can't use science to test things that are completely ascientific. And the worry, the bigger worry though, is the middle part of this paper. So at the end of the paper, they come back. These controls were sort of adopted through the years to, we checked on Mesmer and his mesmerism, and those were sort of the first really well documented control trials. But in between, and we still have this today, when you sort of 90% even understand science without fully getting it, you can sort of use the trappings and the words and the methodology of science to great harm. And so in the modern era, you'll see many papers published on naturopathy, for example, that sound very scientific, but just at their core are not scientific. The concerning features in this paper are when they started using these in essentially the Spanish Inquisition or the various versions of that with witch trial, where like, science, if they don't burn at the stake, they're clearly a witch. And that's sort of a direct descendant of this case, even though like it's brilliant. I really love the idea of non-consecrated holy water to try to figure out if this was real or not, and they came to the right conclusion because it clearly was not real. But half knowing science can be really dangerous, which I think is a really good warning from this paper.
Yeah, well, you could argue it's the world's first placebo trial, and Pfizer wasn't even involved. So there you go. I'm going to get in so
I don't know the religious stances of our audience, and I'll try not to say anything too inflammatory. But yeah, it's really quite interesting.
The other thing I'd like to point out, just if Ken Milne ever listens to this podcast, and I'm going to send it to him, one of the original skeptic academic was a chap called Jean Gerson, who was actually predated this, and he was sort of the original skeptic, if you will, about sort of all things science, and he wrote a number of books on it. But there's a picture of him in this paper, and he looks like the angriest man in the world. Like, he just looks like the most evil, terrible person you could possibly imagine. He's like the antithesis of Ken. He's always smiling. So you don't have to be cranky to be a skeptic. You can be happy like Ken as well. So there you go.
That's good. I was wondering where this was going with Ken, because I thought it was the idea that we've been railing on about science for a decade now, and literally nothing's changed in medicine. So maybe we're all getting more and more cranky. But you're right. There is nobody as joyful as Ken out there, and he's deep in this. So
I think
maybe
that's what I'll take
one day too.
That's what we'll take away from it. You can be a skeptic, but you got to be happy. So there you go. Yeah, enjoy the work as you go along. All right, mate. We've done well. I think that's an hour. Perfect.
I mean, we still made it over an hour despite having half the papers of a usual post. So that's good. It's good that no matter what, we'll fill our time by rambling on. I'm sure our audience of 10 will enjoy it. But yeah, no, it's great. Great talking to you. Hopefully we'll have another set of 5 or 7 articles next month, and we'll continue on through the summer in the proper hemisphere, and we'll go from there.
All right, mate. Good to speak to you, and I'll catch you very soon.
Take care, buddy.